So let me share my screen. So welcome to this webinar, which is right now focused upon the clinical research in pelvic surgery. Why? Because we have been talking about a lot in all these situations where we look at the scenario where we have a accident load, a trauma load to a large extent in our country. And in this kind of a trauma load, whenever we compare it with other countries, I think we have got very high load in developing countries as such. If you look at the literature, there is a very interesting paper published about 3 years back, which was a survey in the developing world, which says they had a survey of 75 institutions, that in 50% of the surgeons at that stage, there is no trained persons in pelvic surgery, then patient might have to go to a very long places to get, even the CT is not available in many of the places. And the problem which are much more in the developing world, that we have got more of neglected cases, whether the lack of awareness in the people or the lack of expertise, and then we have delayed care facilities, and then we have more of these complications due to delay, due to neglect, and so we need to take care of them also. The good thing is that this pelvic trauma is fascinating field now in overall trauma. So we are getting a good number of young surgeons interested in pelvic surgery, and incidentally now we can really say that we have got very good, excellent surgeons in our country, and hospitals have also become very well. But one thing is very typical for this subspecialty, that to be experienced needs a lot of cases, and if we do not have at individual place the number of cases, we need to consolidate our experience. We need to define and learn from each other. It's a kind of a learning curve which we need to work it up. And as far as training is concerned, we are regularly having the AO courses within our country. We are having other kind of a courses with all the international faculty attending our courses. We have got this Pradeep, who has been instrumental in getting a specific course in Mumbai regularly, and we have these cases. And in Lucknow also, there is another place where we are also getting regular cadaveric courses done every year. And then this group, this is the surgeons, pelvic surgeon. We started working in 2009 when we had the name as AOPAS, and that was the first meeting we started with it. We started doing annual meetings, and then somehow in 17 we changed the name and that took some kind of a composition, and we were going reasonably okay till this year when the COVID actually affected our March meeting also at Ahmedabad. But this has been going now. Now I was looking for the published work. So when I put up in PubMed, fractures in India, we have got about 6,000 publications. And if you look at it, these are all publication last 10 years. Then I wrote acetabulum and pelvis fracture in India. I just got 9 results. Incidentally, 4 are mine out of those 9 results. But I further went with pelvic fracture in India and acetabulum fracture, these 3 words. And here we are able to get about 86 publications. And again, you see, most of these publications are happening in last 10 years. So one thing is clear, that yes, now more and more people are writing the research work in India about pelvic trauma. The problem is, if you look at the countryside, the population, there is a huge need to have this kind of a records to be maintained. And these records, I mean, they need definitely a kind of an expenditure, the kind of management. And here I quote Chris also, whose paper I have quoted over down there from 2003, the needs and the cost involved. Basically, that stays our long-term aim, that we should have a kind of a trauma registry with us. But for any registry, we know about the joint registries also, what it needs. It needs a proper documentation at the time of starting it. In joints, it's not a very big issue because joint is standard, the knee is standard, the perceptions are not very many. And then in the implant also, you have got a definitive things to talk about it all. But in a situation like trauma, the situation is little different. Here, everything is this thing. And that is the point where I want our international faculty to guide us. Because if we have to develop, now they are working in one of the best centers across the world. So we need that kind of a guidance. And that is the reason I really feel very thankful to these three luminaries from Cyril, Chris, and Mehul, that on this Sunday, where everybody has got his family time, they have been able to devote these very precious hours with us. So thanks a lot, my friends over there. Now, what is important in this documentation, what we want to learn from them is how to have that uniformity, because even in country right now in our association, we have got more than 200 surgeons with us. If a number of all these surgeons start documenting their individual, because registry is a long-term aim. If we start documenting our each patient according to their profile, then we can have a documentation of the patient, the morbidities, the injury, the investigation, workup, and then the operative findings and the rehabilitation protocol, taking care of the ethical and the consent and confidentiality level. These things are likely to give us a uniform kind of a documentation, which at any stage we can do it at. Now, if they are in a pre-formed performa, pre-printed performa, as this literature says, these kind of records become better. That is what our this is. This another paper also says that if we have got a proper performa, the documentation becomes much better. It is significantly better if our performa is able to take up all these points. If it's a free paper, we may not be, but if it's a proper documented performa, definitely we become better in this kind of a situation. And this is from British Orthopedic Association, which it is said that during the surgery also, if we analyze that data, whatever the Krebel score or whatever the way we analyze our documentation data, if these things are done on a properly dictated and properly typed on a template and with a proper checklist, we are likely to improve in our note keeping also. And this adequacy definitely helps in subsequent analysis of our cases in the situations. Even in the post-operative follow-up is always a problem at most of the places. And that is what we want to learn from our international faculty, that how, because this is one of the very difficult area to get to the patients. The good thing which has come up with the time is the availability of these phones now, and the smartphones where we can really have the pictures of the patient. They can send us x-rays. They can, how these can be employed now, because whatever documentation we are doing, it's for the future from today onwards. So all these things are now available there with most of our patients. So we may be able to get part of the documentation done from these things, and then our stays our ethical and legal aspects. And for this uniformity and for this thing, so our friends have agreed to document all these over this area. So I'm thankful to my colleagues here. So in total, this is the way we want to go in for, where we can have a proper performance for documentation, for accuracy, for relevance, for completeness, for confidentiality. But for this, we will have to look for our international faculty, Cyril from Geneva, Chris from Switzerland, and Mehul from Bristol, to start with this informations. Thank you. So we can request Cyril to start with his.
Thank you, Ramesh.
Yeah.
So how much time do I have?
About 20 minutes.
20 minutes. Okay. I may be a little shorter, but okay. Nevertheless, thank you very much for the invitation. I think this is a really important topic, and we've discussed this with Ramesh a long time ago through societies and standardization of care, and how could we better essentially the care of patients through quality research, which can only come doing at least specifically for pelvic and acetabular fractures through multi-center studies. And in order to do powerful multi-center studies, it's crucial to have standardized documentation. And I think the hardest part of all this is the word standardized, because surgeons are inherently trained to do what they believe is the right thing. And the belief of what is the right thing in pelvic and acetabular fracture is hugely variable. For training reasons, for geographical location of the surgeon, we're about to publish a study actually field for us. It's a survey looking at the variability of care. So the concept of how do you deal with a classic pelvic fracture, APC3, LC3, and the variability is absolutely tremendous. We agree on a few of those aspects, but a lot of other aspects in the treatment concept are not agreed upon. And this is not just geographical variation. This is also within the US, within centers of expertise. So there's still a lot for us to do, and this is great. It's a great opportunity. So I don't really have any PowerPoint because I don't think it is necessary for what I want to discuss. But I want to discuss the 18 minutes that I have left into 3 buckets. The first one is standardization of protocols. And if we're talking about a database, before even we talk about a database, the clinical care provided within the institution, we're starting within the institution, has to be standardized. Because if everyone does things in a very different way, then the database may not be as well representing of the facts. And I'm not talking, same technique and same treatment concept, but I'm talking about basic principle of trauma care. So we have an entire book that's about 65 to 70 pages that is updated every day that I will share with you guys. It's available online, and you can access it right now if you want to follow me. I will pull it up on the shared screen, but it's on ortho5280.com, ORTHO5280.com. This is our internal Denver Health Orthopedic website. And we've sort of created this website a few years ago, specifically for residents and research. And I'm going to pull it up right here because the core of our institution is the residents and the fellows. And there is no way that you can develop standardized care in a training institution without this involvement of the residents. So this is it's a little book that gets updated every month. When we encounter missed opportunities, or there are new papers coming out, or there is new evidence, and this book gets updated to allow us to provide standardized care. So you'll see we have our consultation criteria. We have everything that goes from quality of the communication with other teams. This is for residents, but also documentation of the plan through the emergency department. These are more internal processes, which team will take care of which fractures. I forgot to say that on the Ortho 5280 website, you need to go on the resident menu. You click on resident, you scroll at the bottom, and you have resident handbook. And that's where you can download this. Classification of open fractures, initial management, tetanus, how to place traction so that everybody does the same kind of traction. And then as you scroll down, so basic principles of distal femoral traction, calcaneal pins. Then as you scroll down, you have specifics to unstable pelvic fractures. What to order, what x-ray views, the timing. This is our Denver Health Unstable Pelvic Management Protocol, which I think by now, most people are aware of, that we're a packing center, and that's our pelvic packing protocol so that everybody actually does the same in the institution. How to place a pelvic binder, Again, this is with the desire to standardize everything that is being done. You know, placement of external fixator. When do we place a C-clamp? For us, it's never. And when do we place an external fixator? How do we place an external fixator? Supraacetabular versus iliac crest. This is our, polytrauma. This comes from actually a paper from Chris in Park, who we all know has done tremendous work to answer the question of damage control and the evolution of early total care to appropriate care, which is with Heather Valier too. So this is a mixture of algorithms, but nevertheless pretty well defined in our handbook, so that we can treat those patients accordingly based on specific protocols. You know, we have a protocol for bilateral femur fractures. We just did a big multi-center study on this that proves that actually staging bilateral femur fractures is detrimental to patients. Unfortunately, this goes against my belief, and I'm a strong believer that we've had a few deaths in our institution from not staging bilateral femur fracture, patients dying from fat emboli syndrome, and therefore we prefer to X-fix one and nail the other and stage the treatment. But all this is written. Supracondylar humerus fracture. So everything is absolutely protocolized. And the reason why I want to point this out is that I don't think that it is feasible or useful to have a robust patient database or registry without some degree of standardization of clinical care within the institution and amongst institutions. So that's the first point. And this is hard to do. This comes through, like everything else, cultural buy-in from the institutions and from the surgeons, and thorough knowledge of the evidence available. That's the first point. The second point is really critical. It's the second bucket, and it's, I'm scrolling down to it now, but it's the ability to change the culture of the institution to have a process for M&M conference, morbidity and mortality conference. In order to have a robust database of pelvic and acetabular fracture, you also need to have a robust process of collecting complications. And this is a humbling experience because as you will see that you implement this in your institution, we've been doing this for over a decade now, I think 15 years, every week. And Ramesh, who came, and I think Chris came at our institution too. It's every Mondays. It's self-reported complications. So residents, nurses, anybody can add a patient to a list of M&M, and we review this. And this is our data collection tool. And as you become, as the culture of your institution is changing, you will see your complications rising. And this is normal. It's not that you have more complications. It's just that the complications are reported more freely without the fear of any consequences. And the key part here of this is the root cause analysis that defines if the complication is preventable or non-preventable. We review broken drill bits in the pelvis, broken hardware on the pubic symphysis, sciatic nerve palsies, infections. Everything is reviewed, everything that was not anticipated. And it really strengthens your data collection tool because you suddenly have the power to review all your complications and compare treatment strategies and do a lot of potential research on the topic. Now, again, it's garbage in, garbage out, right? It's usual for data collections. You need to be sure that your whole team is involved in this process. And this is the hardest part of all this, is how do you involve a team and how do you change the culture towards getting this process successful. So you can scroll down. I hope you guys found this in the Ortho 52 website. but it's accessible to everyone, and there's no, you're free to reproduce all this. Finally, the third bucket of all this that I want to show you is this is not accessible. It's only accessible for us, but it's our data collection tool that is on a secured suite, business suite model. So we have two things. First of all, I hope you can see the screen, but this is our operation registry. Every single surgeries are recorded, all of them that are done at Denver Health. And you see this is up to date, up to June 6th. And the reason why this has been successful is that it's recorded by our residents. And the residents who's doing the surgery is only allowed to do the surgery if they fill in this database. If they don't keep it up to date, they will no longer participate in the surgery. So we keep everything, and everything is coded. Everything is a drop-down menu, CPT code, procedure details, and then obviously complications. This is generic. This is all of our surgeries. We also have the pelvic and acetabular database that I'm about to show you now. This one is done by our fellow. So again, the fellow can only participate in the surgery if he updates this database. So we have selected what made sense. The debate, and I hope this will be discussed by other speakers, but is how much is too much, and how much is too little for a database. The biggest database we have so far in the history of orthopedic, I think, is the Court Brown, Margaret McQueen, Edinburgh Royal Infirmary database. And when I was speaking a few years ago, I know him pretty well, and I've discussed this database several times with him to Court Brown. He was emphasizing that the database is proportionally robust to its simplicity. And they had a very simple, very simple database of name and medical record number of the patients, and it was a paper. So it was extremely simple to encourage people filling that database up and coming up with multiple papers, as we know. But I think for pelvis and acetabulum, it's a little bit harder. We need more columns in our database. We need classifications. We need the ISS score. We need some basics of how the patients was managed, damage control, external fixator, the way the external fixator was applied. And it becomes quite cumbersome. And we have done it internally. Now, the next phase, and where I think we're behind India, obviously, we're not there yet, but I met with Claude Saji, who I know participated in one of your webinars not so long ago, but he came to Denver Health 2 months ago, and we had a meeting to discuss this specifics, to setting up a small pelvic and acetabular society that would be international, that would include people from having probably 2 representatives from each country, Germany, India, China, France, Italy, US, and come up with a standardized data collection tool to come up with a robust database. And we're in the works of doing this. We're doing the list of surgeons that could be involved to collect this data. It is extremely difficult. It's extremely difficult because who fills in this database? Who's responsible for the accuracy of the data collection tool? And you need a mechanism to verify that the information in that database is accurate, because otherwise it's not valid research. If the AO classification is wrong, you really need a big buy-in. And I think that the best control for us in the US, I think, we cannot rely on the surgeon themselves to do it. We cannot rely on the residents because it's too technical. It has to be the fellow. This has to be in the ortho trauma fellow job description that it is his duty to carry on maintaining this database. And I think that would work for the US setting, for the way that our fellowship are organized. I don't know if it's the same in India or in Switzerland, but I think the ownership of this is the fellow. With that being said, as a summary, 3 buckets: standardization of clinical care, and morbidity and mortality conference are critical. Thanks for listening, and I'm happy to answer any questions.
Thank you. We will have the discussion after the 3 faculty lectures. Then we have a lot of questions. So we can request Chris to start with his presentations right now. Let's see.
Thank you very much. I'm really grateful that you decided to invite me. It has been great. And Dr. Sen and myself have actually just met a few months ago. That was before the lockdown and everything. And I just wanted to share this information with everybody. So we had a rather big course with 70 plus participants that took place in Zurich. It was a 2-day course, and we looked at both high and low energy injuries because we recognized that with the old concepts, it is no longer required and possible to just focus on high energy injuries. We have so many more patients with geriatric injuries, lower energy, so that we actually divided the course up into these 2 main topics. And these guys were helping out. Thanks again. This is where people came from, the participants. And yeah, we had 2 days and had a very nice sponsor. But the main issue that I wanted to share with you, let me see, I can find it, is because we wanted to talk about the documentation. And the documentation that we discussed there is something that we do on a regular basis. I don't know if you can see, you can still see the old, can you see somebody on a treadmill now? Can you see that?
No, we can just see your PowerPoint.
Okay, hold on. I guess I have to stop sharing.
Yeah.
Because it doesn't open up the new file. Hold on. It will soon come. Hopefully. Anyway, what we are doing is we are seeing all our patients on a regular basis, and I think that that is being done by everybody anyway. Let's try again. We'll just keep it. And then what we do is we put all our patients with a relevant pelvic and acetabular injury on this particular treadmill. And what it does is you can see that the patient has to partially undress, and then by means of the points, this is a video that projects onto the back. And you can measure several different things in these patients. First of all, you can see the spine, which is very easy to guess. And then because you do markings at the pelvis region right here, you can also look at whether the pelvis moves normally. And then you can do markings for the legs. And at the same time, you can measure if there are any weaknesses or any inconsistencies at the leg area. We also, the device also has pedography. So you can see whether somebody has a unilateral tendency to put weight on his lower extremity, and how much time the patient spends on his leg. And that is extremely helpful. So here, for example, this is unfortunately in German, but hopefully it's still helpful. So here's a patient that has a hip problem, and because he doesn't walk properly, you can see that his spine moves in a funny fashion. And so this device has been rather helpful in helping us reassessing the patient post-operatively. And so we usually do this kind of test at the 3 and 6 months time, and we document it in our regular database in the patient file. And so that has been very helpful. We've been doing it for 3 years by now, and the results are not published yet, because so this is why I cannot show it to you. But this is kind of my contribution, which I felt like it is going to be helpful to redefine why a patient had a gait problem, and how much was the spine involved. So if there's a patient that has a scoliosis anyway, you can differentiate whether the spine is crooked just because of his spine problem, or if it's the pelvis or the hip. So that hopefully will become our standard of care in general. Right now, within the Zurich area, there have been 2 other hospitals who have started this kind of documentation for their pelvis patients, and hopefully we can put this together at some stage. The other issue is that I told you before that we are looking at geriatric patients in a particular fashion. So we have developed orthogeriatric co-management, and we have been certified for that, which has also been shown during the course. And so you can, I think we all know that when you look at lower energy injuries, you look at different kinds of injuries. So you have to do different times, so different types of documentation. There are other scoring systems, and the indications and techniques for fracture adaptive surgery is also a little bit different. So one of the problems, or one of the issues that we are looking at is how can we assess that a patient is actually adequately mobile, let's say after we've done an SI screw. So we have started to do the timed up and go test. As you all know, the timed up and go test is a test that has been developed for patients with geriatric problems. But in our situation, it actually worked pretty well to differentiate whether or not the patient was doing quite okay after a type of geriatric fracture. And so part of this has been published in JOT a few months ago, and we hope that we have a lot more update in the near future. So this is kind of the standard of care and the standard of documentation that we are currently doing in Zurich, Switzerland. So as far as I'm concerned, thank you very much again, and I'm absolutely open for any questions.
Thank you, Chris. I think we'll take Mehul's presentation, and then we have a lot of questions to ask for. Mehul, can you get in?
Sure, I'll just share now. Is that okay? Can everyone see the screen?
Yeah, quite okay.
Perfect, thank you. So first of all, Dr. Sen and AOPAS, thank you very much for your kind invitation to share experience regarding databases, protocols, etc. Thank you also to my colleagues here in Bristol, Tony Ward and Tim Chesser, for their efforts in putting together protocols and database with myself. So what we'll do is we'll spend the next 15 to 20 minutes talking a little bit about the evolution of the pelvic and acetabular protocols and database, certainly in Bristol, UK. It's important when we think about any protocol or any database, as the previous speakers have already explained, it's important that you try and identify where you want to and what data you want to capture. So if you think about any patient journey, certainly a patient who has a pelvic or an acetabular fracture, these are the time points when you may want to capture data, okay? And so if you're thinking of setting something up new, it's important that it's all inclusive. Cyril talked about the fact that actually, you know, how much data do you collect? But what you can do actually is you can add to a database, but what you don't want to do is to miss out any important data that you haven't collected over 3 years, 5 years, etc. So I think it's really important, if you're setting this up from the start, try and make sure that you've got all your data collection points and your data measured. So pre-injury, the injury itself, bring to hospital, management, treatment in the operating theatre, post-op management, when the patient goes home, outpatient follow-up, how often do you see them, what tests do you do, and when do you say that the journey for that patient has ended? Okay, when do you say you stop collecting data on that patient? All of these factors are really important for any database or any protocol. So what I'll do is I'll talk a little bit about our specific Preop transfer guidelines in Bristol. I'll talk about our referral forms on how patients can be referred into us, a checklist of some of the important things we think are important when the patient lands on our doorstep. Talk a little bit about consent. As with any database or any study, consent is of prime importance. Talk a little bit about the operation note and factors that we should be thinking about collecting. Talk about clinic follow-up, questionnaires that we specifically tend to use, and then length of follow-up. So that's going to be the structure of my talk. There are national guidelines in the UK as well. There are the BOAST guidelines, which is the British Orthopaedic Association standards for trauma, and there are 10 to 15 different guidelines on specific areas of trauma. There are 2 specific guidelines related to pelvic traumas. One is based on management of severe pelvic trauma, and then the second one is specifically looking at urological injuries associated with pelvic trauma. And these are both available for download, and we'll just go on to them as a hyperlink just so you can see what kind of things they involve. So this goes back to what Cyril was saying. It's really important that you have some standardization, okay? And so this is a standard for trauma, which is available nationally in the UK. And it gives a framework and a guidance for people to work against and to judge themselves against, and also then say to the management that actually, look, we're not achieving on this group of factors. We need more money, we need more funding, we need more manpower to try and change things so that we can score highly on all of these factors, okay? So I'll just run through that. And it just shows some indications of what you should be doing if you've got a patient who's bleeding quite massively, what you should do in their resuscitation phase, what you should think about doing if they don't stabilize, who to get involved, what imaging to have, etc. And so there are 19 points in that guideline.
Sorry, we couldn't see that, I think.
Oh, could you not see it?
No,
Nah, we didn't see
we're
it.
not being able to see it.
Ah, that's a shame. Okay, so we could see it when we looked at it before, is that right?
Yeah. So when you share, you need to share the desktop.
Let me
You
just
can-
come out of here again and let me share that again then. So, can you see that now?
We are seeing the master slide, but we are not seeing the next, subsequently, the details in the management of pelvic trauma.
Okay, let me just come out again.
Share the screen, you share the desktop, not the PowerPoint.
Pradeep, I'm going to try again.
Yes.
Okay, let's try again. So apologies about that.
Yeah, that's right.
Is that better? Okay, so apologies about that. So, so this is the British Orthopaedic Association standards for trauma management of patients with pelvic fractures. And what it does is it gives you 19 points about what you should do dealing with certain aspects of that patient management. Okay, and that's available for download. I won't go through the urological one, but again, with a patient who has urological injuries with a severe pelvic fracture, there are certain guidelines which are available on the national website for everyone to follow. So what about referral guidelines and pre-op transfer? And going back to what Cyril and Chris said, I think it's really, really important to have a pathway which is standard so that with these severely injured patients, they get to the right place at the right time and they're managed in the correct way, because we know that'll give the best possible outcome for this particular patient and the best chance of survival. So we again have various guidelines. So this is our protocol for referral of pelvic and acetabular fractures into our trust. We have 8 referring hospitals. So we're in the southwest of the UK. We have 8 hospitals referring into us, and this is available on their intranet for them to have a look at and ensure that they have managed that patient appropriately before they refer them, before they send them to us. And so I'll just run through that. It talks about the emergency management of pelvic and acetabular fractures. It talks about all suspected injuries and the importance of applying a binder. It talks about some specific injuries, so the open book injury, the vertical shear type injury, the lateral compression type injury, and how we expect these to be managed. It also then talks about those patients who don't stabilize and continue to bleed. And again, like in Denver, we have a policy where we tend to pack more than send them to the angio suite. And it gives advice on that. It talks about specific injuries, urological injuries, open pelvic fractures, combined injuries. And then we move on to acetabular fractures, the dislocated hip, and what we expect should be a bare minimum in the management of this. Combined injuries, various investigations that we would request, the fact that we would request these patients to be started on DVT prophylaxis, the recommended documentation and referral. So once they've done that in the surrounding unit or in our hospital, in our emergency department, if the patient's coming from a different hospital, then we have a specific referral form. And again, I'll share this with you. So this is the updated form. I'll just go down to the bottom of it because I think it's important. So we have an email referral system where any pelvic fracture gets referred to us by this generic pelvic trauma email address. And again, everyone can access it. I can access it from home. I can access images from home. So I can have a look at images, and our aim is to get back to these hospitals within 24 hours with regards to a management plan. Obviously, if there are patients who are in extremis, who are emergency patients, they will get transferred into us automatically. But going back to this referral form, what it does is it gives the referring unit some guidance as to what we expect and what to look for. So we want a little bit of demographic details about the patient. We want a little bit about the mechanism of injury, what type of injury they think it is, whether there are any neurovascular complications or problems, because this will expedite surgery, whether there are any other injuries, so urethral, perineal, rectal or vaginal, whether they've catheterized the patient or not, any associated injuries, what treatment they may well have already instigated, the imaging that's already been performed, and then details about who's referring the patient so I can contact them and get them across if I need that patient to be transferred. And then, so for example, say the patient comes in from a referring hospital, comes into our unit, things change. We all know patients change. And if they've traveled about 40 minutes or an hour to come to us, things can change. And so we have a checklist when patients come into us, into our unit, into our trauma unit. And this is something we set up about 10 years ago. And what it does, again, it looks at providing one sheet which is standardized, and it gives you an indicator of what we're looking for preoperatively and postoperatively. So again, preoperatively, we'll run through these: neurological examination, perineal examination, the adequate imaging, both X-rays and CT scans, and then working this patient up for theatre. Have we cross-matched them? Have they been given some thromboprophylaxis? We tend to perform a Doppler ultrasound scan of their deep veins if they've been delayed more than 3 days. We look at MRSA, and now we'll be looking at COVID swabs as well. And all this is then documented and initialed. And so there's some ownership as well. And then similarly post-op. So what we recommend post-operatively all goes onto one sheet, and this stays in the front of the note so we can check through all of this checklist and make sure that nothing's been missed for this patient. Consent. So ideally, we've found the best time to fill out the consent form with this patient is whilst they're in hospital. Sometimes it's not always possible if they've spent a period on the intensive care unit, or if they've got a significant brain injury, etc. But usually we try and get this consent form filled out whilst they're in hospital. So again, ours is a specific consent form for medical records, radiographs, and the pelvic and acetabular database. And I'll just run through this, and it's in keeping with the Data Protection Act in 1998. And what it essentially says at the bottom there is that I, who is the patient, understands that all members of staff will treat any information I provide in the strictest of confidence, and that they consent to the information being used for training, lectures, database collecting outcomes for audit and education, and also for publication and educational purposes. But what it also says is that if you're carrying out a specific study, then as per normal protocol, ethical approval will be gained for, or will be asked for even. Second page of the consent form, this just allows the patient to take part in the database and the collection or not. The patient signs this bit here, and then usually one of the consultants or our research coordinator and research nurse signs this bit, and this goes onto the database. Op note and documentation. So, you know, both speakers, both Cyril and Chris, have talked about this, and I think it's really, really important when we're looking at specific injuries and complex injuries and pelvic and acetabular fractures, that things are documented correctly. And I agree that, you know, what goes in is what comes out, and if junk goes in, then junk goes out. And I think I agree that you should have someone who's at that level, whether it be a fellow or the consultant level, who should perform these documentation. So this is just an op note from a case I did last week. So this is a young guy who was a jumper. And so the bare essential we need is patient information, surgeon information. It's really important that the classification of the fracture is correct. And what we found is that sometimes what you think is the classification changes intraoperatively, because you may find that it's that there's an extension of a fracture line, or that there's an injury to the opposite side of the pelvis, etc. So we've found that the best time to document the classification is at the time of surgery. Okay. Other injuries are really important to identify and to document. Antibiotics, we did an op note documentation audit, and we found that about 20% of the time the antibiotics weren't documented. So again, it's really important that we do this, because if the patient does have a superficial wound infection or a deep wound infection, we need to know that we did everything we could at the beginning to prevent that. So documentation is key. And then the operative the operation in some detail, and then we'll just move on to the post-op bit, because again, this is really, really important to document and make sure we get it right, because it should have a plan of rehabilitation, it should have a plan of follow-up, what investigations are needed, when the patient needs to come back, where they need to come back, imaging and x-rays. So I think that's key. From our point of view, certainly in Bristol, what we tend to do is we have a specialist pelvic clinic which runs every month. It's consultant-led, so the consultant is always there. The fellow, it's a teaching clinic for the fellow, so the fellow's there, or the registrars are there, and they find it a very, very useful teaching tool. All pelvic and acetabular patients are seen at 6 weeks post-op, then at 3 months, then at 6 months, then at 1 year, and then annually for 5 years. The questionnaires that we tend to use, we use the clinical evaluation form, which is filled in at each clinic attendance. And this is what that includes. So patient details in the top corner, clinic date, the follow-up time, classification of the injury, and then some x-ray findings, some clinical findings regarding neurology, a visual and pain score, and some functional assessment of how they walk and whether they've returned back to work. And so this is done at each clinic attendance. At specific points in time, and I'll move on to that in my next slide, we also performed the Oxford Hip Score and the EQ5D. So this is the EQ5D. We used to use the SF36 routinely, but over the last 8 years or so, we've been using the EQ5D. So this is the exact questionnaire that the patient has. They have, again, a visual rating scale to rate their health on that particular day, and then an Oxford hip score. We've done a couple of studies looking at urinary dysfunction and sexual dysfunction, and our last paper that was published about 18 months ago in the American Journal of Orthopedic Trauma showed that actually there's a high rate of urinary dysfunction and sexual dysfunction in the pelvic ring patients. The female lower urinary tract score is the FLUTS, and the MLUTS is the male lower urinary tract score. And both of these scoring systems were actually started and made here in Bristol, and hence these are the ones we tend to use. But actually, we've got an audit meeting coming up this month in the next 2 weeks, where we've invited one of our keen urologists to look at whether there's a better screening tool, a better outcome tool to look at urinary dysfunction and sexual dysfunction. I'll just show you one of these, and then we'll move on. But again, it goes into urinary symptoms in quite a lot of detail. And it asks them about symptoms at night, sudden rush to go to the toilet, any pain in the bladder, etc. There's quite a few questions, and it goes into urinary symptoms in quite detail. So we tend to use that. So questionnaire time points. When do we ask our patients to fill out these questionnaires? So we fill questionnaires out at 6 months, 1 year, 2 years, and then 5 years post-injury. And if you look at the table there, it shows you which questionnaires we asked to be filled out for pelvic ring, and which questionnaires we asked to be filled out for the acetabular fractures. Cyril talked about this, and I think it's really important. So the governance side of things with any data collection tool is of paramount importance. So what we do is we have a monthly audit meeting where we look at all of our pelvic and acetabular fractures that have been treated both operatively and non-operatively in the previous month. We sit down, we try and ensure that there are at least 3 of the pelvic surgeons there. We have our research nurse, we have our research physio, and everyone is there. And what we do is we ensure that all the documentation is complete for the previous month. We ensure that all the BOSTs have been completed for all patients in the previous month. Any complications or reoperations have been documented. And then what we do is we compile the 12 separate monthly audits, and we have an annual pelvic audit meeting. And that's our audit meeting that's taking place in about a fortnight's time, where we go through all of the previous year's work, previous year's complications, and these are all documented. So I'm going to stop there, but I think it's a fantastic project to move forward with regards to getting a minimum data set to push forward with a national pelvic and acetabular database. Yes, there are challenges, but actually the way you're going about it, including and involving people who have some experience with data collection, what has worked, what hasn't worked, is the way forward. And you can just see by today's webinar that it is important and that people are keen to support it. So well done. Thank you very much.
Thank you, Mehul. I think we have got questions both on this chat box also. Then I'll be asking first these questions, then we'll start discussion. The first question as we come out to it's for Cyril. Do all institutes have fellows in your system, Cyril?
So, I mean, every level 1 trauma center, I mean, let me rephrase that. There's about 100 fellows in the country in US. It's a national matching program. Some institutions have 4 or 5, which is really unusual, like Shock and Harborview. The majority have 1. So it's a total of 100 fellows per year, probably about 50 institutions will have a fellow. Doing a database, then, I mean, it depends what you want to achieve. If you want to do a pragmatic database like the Joint Registry in the UK, which is really, you know, a prime, high quality registry that captures a whole variety of set skills, those doing, you know, 70 a year, those doing 200 a year. This is great because we also want to prove that the point of the database is also to prove that the outcomes are so much better when surgeons do more of those surgeries, which has been proven for joints. We know it's obvious for pelvis and acetabular, even more so than joints, but we can't prove this until we have a pragmatic database. So I think the question is, do you restrict this database or this data collection tool to expert centers? You will have a flavor of the reality, or do you have a more pragmatic approach where you include you know, district general hospitals, like in the UK, for example, that may do 2 a year, although now everything is centralized in the UK too. So you wouldn't capture those, but you may have centers that do much less and centers that do a huge volume. And then you also should divide, that's a big topic for me, is how many pelvic and acetabular surgeons are there in the center? Because you look at certain institutions that I will not name, where yes, they have a big volume of pelvis per year, but this volume is diluted amongst 8 or 9 surgeons, and they all end up doing 15 of those a year. And then you have other centers where you have 150 pelvis and acetabular fractures a year, divided by 2 surgeons who each do 70 or 80 per year. And I think the quality of those centers is far better, but yet less known. And those, hopefully those databases and data collection tools will help us do that. As other speakers were talking, I was thinking of a bucket that we haven't talked about. Unfortunately, there's no time, but it's what outcome measures do we utilize? And I want to share our experience very briefly. We have used a generic score and a disease-specific score, right? Like the majority of people. So SF12 and Majid, or for pelvis, and for acetabular fracture, which score we used? We used the French score. The name escapes to me now.
Mel Daubigny.
It's French. Mel Daubigny. Thank you. But we're changing this. There's a huge body of literature in shoulder surgery that recommends and suggests and validates a one question score. Literally one question is in relation to your and this works for trauma, in relation to your injury status, how far are you in percentage to what you were? And the answer may be 80%, 70%, but this has been validated in many areas of orthopedics, and I think really is the future, because the cumbersome part of all this is collecting functional outcome. And if we can come up with a simple score that you can get over the phone, we don't need range of motion. You just need over the phone to say, hey, Mrs. Whatever, how are you compared to where you were? 80%, bang, you got your functional score. So we've started last month actually collecting this score as a unique score to validate it specifically for pelvic and acetabular fractures.
Chris wanted to tell about the red cap. So Chris, do you want to elaborate more on that?
Absolutely. So RedCap is like an online database, and you can basically you rent it. You can put down your own database, and you can basically get it from everywhere in the world. So you can share it with whoever you want to. Of course, it's not for free, so you have to rent it, but it's a very good system. We have from our institution, we have 3 different RedCap files. So we use one for spine, one for the pelvis, and one for lower extremity. And that can be shared. So if you want to do a nationwide database or worldwide even, it's very easy to use, and it makes a lot of sense.
Okay. So there is a provision in that. The another question which was there was, yeah, there was a mention, the book name again, they wanted Cyril to tell about that, his online availability of that book. People want to know about that.
The address is ortho5280.com. And so ORTHO5280.com. 5280 is the mile high city, is the altitude of Denver in feet. That hence the number.
Okay.
But yeah, no, it's our internal website. And if you go under the residency menu section, at the bottom there is download our resident handbook.
Okay. There is a very important perception in our country, because in India we don't have this surgery being done in institutions only. We have institutions also, and we have individual surgeons also doing. And the second perspective is that the individual surgeons, the volume will not be as high as institutions will have. So the difference in the various setups gives different numbers to the surgeons concerned. As an institution, yes, we may have the policies as adopted in your institutions at Geneva or Zurich or Bristol, but most of the persons who are doing it are also in individual practices, where if there is a certain kind of a guideline, as Mehul has shown some of those, if we are there. But what I learned from the first three talks is that first we should have a kind of a protocol which we can put up for analyzing whether we have followed protocols or not. And on the documentation, we have to stick to these protocols first, because any documentation has to go with the protocols only. So maybe, I mean, it could be the retrospectively, if we have got a checklist made, we can ensure our working according to the protocols also. So whatever documentation we are doing, we are actually being guided by the documentation to our work also. So if we are looking at our documentation, accordingly we are evaluating our care. Probably that could be the way for us also, especially when we are working in a smaller centers and all those surgeons. So next question I will take it up is, yeah, the question is.
Can I interrupt a
yeah,
minute?
please.
Yeah, so I think from the first three talks, what I can summarize is that first thing, we have to have a standard of care. That is the most important thing, that it is protocol driven, it is written down, and it is agreed upon according to our social and regional parameters. Like for India, we have to have a proper standard of care for pelviacetabular management, fracture management. That is our first thing. Then second thing is our standard of data collection. It has to be also standardized. So that is what we need to, and probably that will also be different because of our population having a different kind of expectations, including sitting on the floor and squatting and all those things. So these two standardization is our first goal, and then probably we can look forward to, you know, then processing that data and creating research and creating a registry.
Yes. So then the next question was, Red Cap has already been answered about it. Anything, Pradeep, from the...
Dr. Samuel Hailu had asked what system they use for data collection. So I think as what Mehul showed, it was a form, it was a paper form. So it is filled on the paper, and then probably somebody enters the data into the software. And probably what Dr. Pape was saying was a directly software entry, which is through the Red Cap. So can you people elaborate on that? Dr. Samuel Hailu from Ethiopia has asked this question.
Yeah, so I'll start first. You're absolutely right. So part of the data is on paper form, and then it's transcribed onto the database. All our operative data and our outpatient collection of data is then put onto the database, which is run by Blue Spear directly. So that's scanned in, and that's available there on the database. But you're right. So then if you have that process of collection and scanning, you need to be aware that there needs to be someone dedicated to do that.
Yeah,
Dr.
that's quite.
Pape?
Chris wants to say something more about entering the recording of data. As you said, it is directly over to the electronic thing, Eddie. Or there is any paperwork in between, or somebody else does this documentation over the net?
Yeah, I think, yeah, you have to set the threshold levels yourself. So that's an important task. If you enter data, let's say in any of the big databases such as TARN in the UK or National Trauma Database in the US or the German Registry, which is pretty much all over Europe, then the system does not allow you to enter completely wrong numbers that don't make sense. So that needs to be done by yourself if you use one of the forms that I entered into the chat. So basically that needs to be taken care of.
So I have two questions.
Please.
So first question is to the foreign faculty. How do you store your X-rays and how do you integrate your X-rays with the forms that your SOP forms and the individual patient data forms? That's one. And secondly, how intricately are you involved with your databases on a daily basis in terms of checking what goes into the database, whoever is filling the form?
Yeah.
So
Mehul, can you? Yeah, Mehul can reply.
Yeah. So I'm happy to start. So taking your first question, I think the more and more sophisticated databases have become, I think it's possible to merge your X-rays, CT scans, images, intraoperative images with your operation notes, with your clinic notes, etc. We haven't reached that stage yet. I have been on a couple of committees to try and create a national pelvic and acetabular database, and that's what we were hoping to go towards. It hasn't happened yet, but I think I'm really keen on doing that because I think then it gives you a storage facility for all of your data in one area. And what it also does is it allows you to share, if you've got those privileges, with other units as well. So you can give another unit the privilege to share your data, having been through all the GDPR, etc. So I think that would be ideal. With regards, your second question, just remind me.
So how much of involvement do you have on a daily basis in terms of checking and verifying what goes into your database?
Yeah. So the pelvic and acetabular surgeons in Bristol are very proactive. They are really keen on identifying the injury, classifying the injury. They will input a lot of the data, so we'll do it ourselves, sitting there with the fellows to do it. And then we have our stop check. So on a monthly basis, we go through all the cases the previous month, and we will ensure that everything's been documented and everything's been completed. So we do it as the surgeons.
And Chris, what is about on the REDCap? Whenever you enter data, are the X-rays and every document is getting attached with the patient's profile as such?
Well, it really depends on your local situation, because you have to de-identify the patient. That's one of the issues. So you have to make sure that before you will enter data, your IT people allow you to do this, because it can be a real problem.
So just to understand the situation, do you sort of integrate your packs or wherever your X-rays are stored with your individual patient forms, or how do you do it? Or whenever you need it, you have to extract the X-rays on a case-to-case basis?
It's a very important question. So you basically have to have some ID that doesn't directly de-identify the patient. So you have to have some secret number that you use if you put this on a, on a website that is potentially if there can be any fraud, you cannot put official patient data on that website.
I'll just add a little bit to that from our point of view. So from our point of view, we have one database which has all the patient records, outpatient clinics, operation notes, etc. And then we have our X-ray PAC system. And so our database, if we want to look at specific patients, we look at them in PAC. So we haven't yet merged them, but with other sophisticated databases, what you can do is you can upload anonymized images and various files. But again, as Chris says, you've got to be really, really careful that there are no patient identifiers.
So we've tried our hand with a couple of databases of different kinds. And the problem that we've usually faced, and that is where the data just gets lost, is that on your record, you have videos of CT scans, of axial cuts, of 3D cuts, and those take a lot of space getting into any database, which makes a database very, very slow. And the actual process of putting it in and taking it back, or unifying the method in which you will downsize an image and still retain the clarity and still put it in a database so that it's retrievable and linkable. Because then the problem that happens is that if you lose one set, the other set is of not so much value.
Yeah.
I don't know how you evolved into your systems of having recording of X-rays and the forms, the patient-specific forms, and integrating the two. So how have you gone about doing it? You must have started somewhere. It cannot have all come as a legacy. Because we seem to have played around with a few systems and have lost it. And it just not come around to doing something standard which has lasted for a while.
Sure. So ours is two systems at the moment. Ours isn't one, Abhay.
Yeah, so what we understand is that there is a system in which you will standardize. There will be the information, but no documentation. As far as no X-rays, nothing. It is just an information database for a patient in a given registry. And all these things, Excel and everything, they will remain in your basic, with the patient care folder. That's what I understand. So whenever you are making your oral assessment, you are looking at this thing, and then you are going to retrieve your PAC system from that PAC system.
That's right.
That's what I understand. And what about Cyril? What do you have got? Do you have amalgamation of your X-rays and all things?
So for us, for our database, X-rays, I mean, we have a PAC system. X-rays don't matter. We will, when we want to do a retrospective study, I mean, the X-ray are documented in the database. So quality of reduction, the quality on the CT scan, the hardware placement, the type of screw position, the quality of reduction at post-op, but the X-rays are not stored. They're just in the PAC system. We don't use them.
So when you're going for an analysis, so it means you're again looking back at the X-rays to define your needs, isn't it?
Yeah, I mean, all those studies are retrospective studies of prospectively collected data. They're all, we want to look at our T-types, and we'll just pull up from that database T-type fractures, and then we will look at some factors of the X-rays that may not be captured in the database. For example, at the clinic follow-up, at 6 months, for example, we do not have any X-ray data collection tool. We get X-rays, but we don't document the quality of the X-rays besides documenting in the clinic note. We just collect functional outcome at 6 months. But for the purpose of the study, whoever's doing it will retrospectively evaluate the quality of maintenance of reduction at 6 months.
Okay, so we understand that there is a system. As Mehul said it, we need to have two systems basically. One is a retrieved data which is used for a registry kind of a information, and one is the basic set which has to stay with the hospital at any stage.
I think keeping X-rays in the registry will make it impossible in terms of even just in terms of data usage. It becomes costly to have 1 million X-rays from 1,000 patients. It would become unmanageable, I think.
Okay, so Pranav, do we have any more important before we start over the next part?
We should go ahead to the next part because the time is a constraint now.
Yeah, that's what I'm thinking. So Vivek, are you there? We can start with the, now I want the faculty, the international faculty to comment and guide about it. So we have got our preparations. So Vivek will start with the pre-operative workup or the pre-operative documentation. Vivek, are you there? Is muted, his visual is, yes, that's right. Vivek.
After listening, sorry that I was slightly out in between. And what I have thought about is that in India, as we have also discussed out here, there are varied problems. The first thing is to get a standard of care, as was being referred by Pranav, and also to get the standard of treatment and then the standard investigations also which will be there. So what we require is, if we look at it, pre-op documentation, as we have all seen, is very important. And in Indian perspective, I would say, besides giving us a registry, it also helps us in medico-legal aspects and give a standard of care treatment plan for the people who are working in various setups in India. The problem in India is not that is of varied standard of care which is being given everywhere. We can have 2 or 3 or 5 trauma centers, level 1, giving us the entire data in details. But we also need to cater to all the people who are working in smaller areas who will also have to get some sort of a documentation which is required in the pre-operative stages. And so we might have to have 2 levels of it. One is the basic level and one is an complex or an advanced level, which can go into all the details which are available with the various centers which may classify as level 1 in our setup. So I have grossly divided them into 3 or 4 types which are there. And what I feel is a pre-operative documentation for any fracture, and especially a pelviacetabular fracture in India, will require a demographic profile part, an injury-specific data, radiological evaluation, and some sort of stabilization which is being done pre-operative. So these will be the 4 major headings under which we can have some criteria which over the periods we can discuss and have a consensus regarding what needs to be a bare minimum which needs to be followed in such cases. Coming to the demographic profile, we all know all the age, sex, occupation. In India, the problem is going to be the address. Most of the people are migrant coming from far off, do not have a permanent. So follow-up is very difficult. And what we are following in our center is having their permanent account number or an Aadhaar or a national ID, or having their mobile and personal permanent address of their village, so that if we really require to talk to them later also, we are able to get them back in our mobiles change, numbers change so frequently in our country that you cannot rely on that. Personal histories, addictions, these things are important. Income, because these will be, and most of the factors which we'll be discussing, we all are thinking regarding making a registry or having some points which can be taken up and pooled together to have some value addition, information, data analysis from them. In India, mechanism of injury is a big thing because we have got all sorts of things which happen in our country. Passengers and driver, where exactly he's sitting, helmets, fall from height, standing height, osteoporotic is increasing, and then how he is being getting transported to hospital. I can assure you that even in Delhi or a major capital city of our country, this transport to hospital is going to vary from hospital to hospital and from area to area. And that divides, shows us our country, which is having so varied expectations as well as presentations, which becomes very difficult to have it in this setup. and then when we do for timing of surgery. All these standard criteria of comorbidities, ASA grades, pre-existing arthritis, pre-injury status of activity should be there, and should be there for all our pre-op evaluation systems and documented by our fellows, because these are going to help us in our post-operative and evaluation and follow-ups as well. Regarding injury specific data, as I said, what has happened in the pre-hospital care, whether it has got anything which, or the patient has just been scooped and run and brought to the hospitals. This is a crucial issue because many hospitals may not have the first in-hospital physiological variables which are so much required for developing any data system. We have it in our hospital, which is ensuring that this is a proper pro forma which is being filled up for all the cases and for the trauma registry which we develop. Following up for all the ABCDs, ATLS protocol, FAST and eFAST which are done, which may not be possible in other places, in smaller places, and looking at the stabilities and resuscitation maneuvers. Especially for pelvis fracture, if we go, the pelvis fracture documentation is going to be much more difficult, or we have to discuss, because the real efficiency of a hospital is shown by how you manage a pelvis fracture. And that is going to vary a lot in our standard of care in various centers. Whether we are putting in an X-Fix binder, and this can be yes ticked or no, yes or no, which are being ticked up in our hospital. Pre-peritoneal packing, skeletal traction, embolization, and also the tranexamic acid, and looking at the CRASH 2 and other trials which we have been doing, and we have got the results. What happens to the transfusion and all the levels which we have to look for, especially in pelvic fracture cases, because there the aspect of hemodynamic instability also plays an important role for our country. And I feel that this will be an issue when we discuss that, because how many people in our setup are going to be doing this is the question, and having a thromboelastography or an INR which is available immediately for them in the emergency department. What we also need, this is just a basic thing which I'm talking, which we should be incorporating in all the setup, associated other organ injuries, which are so very important, especially in pelvis fractures, other skeletal injuries like upper limb, lower limb or spines, morale level lesions, open injuries, abbreviated injury scores, or the injury severity scores, which will be calculated once we have all this data. And what we have done in the emergency departments regarding neural, vascular, and reduction attempts. Radiological data is the most important, and I feel that getting the 3 views CT scan with less than 3 millimeter cuts has to be mandated out here, and we'll have to get both the 2Ds and CTs for them. Looking at the incongruent and unstable acetabular fractures, the various signs which need to be incorporated into these should be a part of our checklist, which is seen by the surgeon, both for his documentation as well as for his medical legal aspects and for the information which you are going to get. The 3 views are a must. 2D CT scan, how to get a uniform thing, because the scan is a problem in our country. A 2D scan from L5 vertebra to lesser trochanter, all getting all the scans, especially these 4 scans at the level of SI joint, supraacetabular dome area, wall area, and the inferior and the pubic rami area, which are so important to get a view. 3D CT scans, all the 4 views which are standard nowadays, AP, posterior, outside end-on view of the hip joint, and a stopa view or an intrapelvic view. These 4 CTs should be there for all the 3D CT scans. And to classify a fracture, I would say that that is the most important reason, and that's why I have put in a checklist for that, because the accuracy with which a person is able to classify a fracture is going to change your entire documentation. Just relying on a person in India who will be having rare fractures, so we have a checklist looking at whether the obturator ring, all the lines are broken, the standard way by which we identify an acetabular fracture. He ticks them off, and then we get, this is an app which people have been using in the world. So we can have some way by which, looking at these 6 or 8 criteria, we can know for sure what acetabular fracture are we talking of. rather than just relying on the diagnosis, which can vary from even from expert to an expert regarding T-type or an AC-PHT, which is so very, very difficult out here. Pelvis also is the same way. We have to get the CTs and the things. Classification by Young Burgess and AOTA classification will be required. And getting again a checklist of what all we are going to have a look in the preoperative. Because to get a diagnosis, management indications, we need to have the displacements. Just not that we have to look at the displacements, symphysial, pubic remiz, sacral, at the various classifications, CT scan showing the dysmorphism, the transverse processes which are fractured. So these all need to be incorporated amongst them. Among the CT scans also, we need to have all the sacral CT or a posterior CT looking at the Dennis classification. It's not only a sacral ala fracture. We need to look whether it's complete or incomplete. Many things have to be looked for CT, which can be documented in this fashion. Lateral view in a CT scan, sagittal view is mandatory. Looking at sacral dysmorphism, opening of the SI joints and displacements is also having preoperative things. Besides that, looking at the DVT prophylaxis, what is being given, chemical or physical, any ultrasounds, and the various interventions which have been done for other organs like abdomen, rectum, SPCs, and the bladders, and the moral level lesions, and how the spinal injuries have been tackled before taking care of the pelvic injuries. So just to show you that this is a record keeping which we do in our Excel sheet in our hospital. We have a Pelviacetabular fellow who is helping us, but this has been done right from the initial time when we started 2007 onwards. And I have been keeping all the records of all my data, whatever is there, address, associated injuries, mechanism, fast, comorbidities. And that's what we all need to have first in our individual setups, and then look at the possible qualifiers and the things which we want for a national registry in true sense. I'll conclude by saying that it is essential for a standardized and uniform data collection that we first do it ourselves as individuals, see what is possible with us, and then go about having a consensus regarding what needs to form the bare minimum for a registry, and especially in our country. One thing to remember is it is not only the quantity. Just because India has got the maximum number of pelviacetabular trauma cases nowadays, that we will have a good registry, it is not possible. Just mere the quantity, we have to stress upon the quality, how the things are getting diagnosed. Is the classification being written is the right one? We might have to have a checklist for that, and having all the things recorded properly in an objective fashion, rather than just relying on a center to center or an individual to individual basis. And these 3 or 4 criteria which are important of demography, profile, radiological status, and the preoperative interventions to stabilize a patient are going to form the crux regarding preoperative documentation. Thank you. Thank you, Mike. Mike, unmute.
Yeah. So what I was saying is that if we have got this kind of a document available in which we have to see that every step is checked up, in this way we will be standardizing our management also, because we know that these are the particular steps to go on, and once we are going through, it makes us systematic in our recordings also. And that is what we are looking for. Now, there are some issues. As far as the patient profile is concerned, it's very important, as you have added, Aadhaar. Because in the days to come in Indian setup, Aadhaar could be one number which is likely to stay with the person for his lifetime. So that is an addition which we must be having in our protocol. And then out of demography, and then we come to the patient status. Obviously, a patient may be coming straight forward to your institution or might have been referred at various levels. Now that creates a kind of a difference in the assessment also and the management also. So I don't know whether I want an opinion of the foreign faculty here. If the patient is coming from another center, how his previous data is incorporated into this system which they are doing. Can we start with somewhere? Can we start with the Mehul?
Sorry, Dr. Sen, just repeat the question again.
My question is that if the patient has come to your place straightforward or your system straightforward, but in India, you know, the patient does not come from any status standard. He's managed somewhere. We might not have enough documentation about his condition before he came to us. And we need to maintain beyond that. So do you have any kind of this kind of a situation, or your patients are already, in all cases, are well monitored and well informed to you also about their status?
No, so you're right. So most of the time they'll be from one of the 8 surrounding hospitals that they come to us. But we do have patients who come from abroad. We do have patients who come from Scotland and from Wales. So with those patients, we will encourage them to be followed up with us up until 6 months minimum. And then we will offer them further follow-up. If they end up going back to be followed up elsewhere, so
just a minute.
Oh, sorry.
I'm looking at pre-op, before the start of your care, pre-operative workup. If they have come from a place where you do not know about what has been done to them, I'm looking at that profile.
Right. So yes, you're right. I mean, we don't always know what's been done with them. We usually need to work them up again and then make a decision as to whether we think what's been done has been the right thing or not.
So how do you feel that data over there when you are assessing a patient in that kind of a document?
Yeah, that's right. So what we tend to do is if someone needs something else doing, or something needs revising or changing or something, then at least 2 of us make that decision.
Okay.
I think the documentation has to be absolutely perfect from day one, because you need to make sure that there are no infections. You need to make sure there are no neurological problems, because patients may have had sciatic nerve palsies, etc. So you've got to start from first step again. And what we do is we will fill out all of the documentation that we've said, but we will take it as the first time we're seeing the patient, but obviously document if they've had procedures done already.
Okay. And Chris, do you have anything to add into this kind of a situation? Do you have these patients coming managed somewhere in the initial period and then they are referred to you? So we are looking for how do you add their data, which we do not know at that stage. Do you have that situation, Chris?
He's not with us, I think.
I think somehow it got disconnected.
Yeah, Cyril is there.
No.
Both of them got disconnected, I think. So.
Okay.
Dr. Sen, I'll say one other thing. So we're fortunate. So if they've come from the UK, then we will be able to get some data from our TAN database. So we will be able to get date of admission, date of surgery, and we'll be able to liaise with the other trauma center and try and get some documentation.
Okay. And now coming to the second question which I have got is that which classification system you are likely to use? Are you likely to go for a AO classification system for pelvis and vestibular injuries, or you're likely to go with the conventional systems for classification? Because your patients will definitely be put up those criteria, which classification it is.
That's right. We tend to use the tile classification for pelvic ring and the Letonel for acetabular fractures.
Okay. So you don't have any part for AO systems?
So we don't, unless we are doing a study or a research program. And then if we are for that group of patients, then we will classify them according to the AO as well.
Okay. Okay. Anybody else wants to have any of these things? Any inputs from Krishna Kiran or Abhay or Pradeep? For pre-operative workup, we are looking for pre-operative workup.
Regarding a previous question also, I think the documentation on the radiological parameters, whatever are the criteria must be filled into the form. I don't think we can keep the x-rays at any point. Abhay was asking about that. So whatever is a classification system based on whatever criteria has to be entered in. And whenever the patient comes for follow-up, you just fill again the radiological criteria and the clinical criteria which we need to collect. That's all. So data is already collected. I don't think we can go back and then again look at the X-rays or something at some other point in time, because it will be a data from various centers. It will not be practical to store the X-rays as such.
Yes. So what we personally think is that this data, which goes as a kind of a registry, will just have information, no documentation, no documents.
Correct. Correct.
Yes.
That's right.
Yes. So that is what I take it. Abhay, anything to add? Or Pradeep?
Sir, I think that there regarding the classification, as Dr. Rika also has mentioned, there can be variations. So at least the initial X-rays, I think that needs to be stored, and at least if we can have 2 or 3 people who can validate the classification, that can put little uniformity in the data of the with regard to the classification, because we have seen there can be quite a bit of variation as far as when you are classifying these fractures.
The problem is, if you are looking up as a registry, as a eventual thing, there the consensus has to go with whatever the classification has been done.
Yeah.
At individual level, we can discuss that, define that, and then put up that.
Yeah. Yes.
But so eventually, what goes into the registry should be the information only.
Yeah.
Yes,
correct.
So for a registry, you cannot have X-rays. You will have to
Yeah.
trust the people putting in data in the registry. But on the fall side of things, a lot of times you relook at how the patient and the injury behaves down the line in a follow-up situation, and you realize that probably the interpretation on day one would have been slightly different. So those are the fall sides of having data and information on the registry. But that can be done at an individual level as a relook situation down the line. For that, again, actually, you need the data and the X-rays to be stored at one place.
Okay. And
I personally think, sir, there is no way that we can expect that there will be a very standard and very accurate filling up of the classification system, because there is, I mean, even if we share among us X-rays, we very frequently each one classifies it in a different way. So I think initial phase, as Pradeep has suggested, the classification part will require to be amendable by 3 or 5 designated people, that they will go through all the entries. They may get on their own personal phone or in their WhatsApp, they can get that images, and they will reassure that the accurate data entry has been done.
yeah, that's right. What I mean to say is that when we are putting up on a document which is to go everywhere, we cannot have ambiguity at that stage. Whatever is decided will be decided as an entry point, and that will be taken as such. So as far as the preoperative workup is concerned, I think what Vivek has done is tabulated. And what I was looking at it, that if we can put up in an electronic form where we have to say tick either this way or checklist kind of a thing, if this all format comes, then probably it will be a kind of an app with everybody of us, and then we can just keep it up for the registry purpose.
Actually, it should be a form where the only thing that you have to enter has to be a yes or no, or maybe a qualification of the question.
Yes, because the details are something which we can add on while we are creating our own data, and whenever we require to amalgamate all the data for a specific thing, we can work more on that. But especially just because the registry, as Mehul was saying, cannot be exhaustive. It has to be simplified. So the common registry must be very simple, standard. And while the individual registry, as he says, there are 2 registries, one in his hospital, one is for that amalgamation. So one amalgamation will go a very basic registry, and one for himself will be a complete, whenever desired, they can be amalgamated according to that. Is that okay?
Yeah.
So we can proceed further to Abhay for the intraoperative documentation.
Okay. This is not moving forward. Right. So why do we need intraoperative documentation, because we understand that how a patient or a fracture or the functional outcome is going to behave essentially depends on a lot of issues. For example, in this review by Ziran in 2019, they say patient age more than 40, a poor fracture reduction of more than 3 millimeters, multifragmentary fractures of the anterior or posterior wall, transverse multifragmentary fractures including the roof, cartilage injuries in the head or the acetabular cartilage, a delay of surgery of more than 5 days for the simple ones and more than 15 days or 2 weeks for the complex associated ones, and an initial displacement of more than 20 millimeters are essentially the factors which will govern how an acetabular fracture or an acetabular-pelvic injury behaves down the line. And the same thoughts have been echoed across the last decade by a number of authors. For example, in this publication by Giannoudis or a commentary by Dan Mears, where they have basically talked of the same thing. In addition, they have also talked that what is important to understand is whether on your reduction or your per-operative performance, you had a deformity or a malreduction in the plane of the anatomy or perpendicular to the plane of the anatomy. So a step which is perpendicular to the plane of the anatomy of more than 1 millimeters is going to cause a faster and an earlier osteoarthritis, and a gap, that means a deformity or in the plane of the anatomy of more than 5 millimeters is going to cause an arthritis, which is going to be slower and slower progressive. So gaps more permissive or more forgiving than steps. Then impactions and combinations, especially as we see in elderly osteopenics, are very important to document, to understand, because they predispose to late deformities in total hip replacements. And these are the basic situations where you might need to do an acute total hip. So posterior wall, posterior column fractures, I will not go so much into injury as such, because this is just us. And we would look at the kind of recording that we've done. So essentially, a posterior wall, a column and a wall, or a column. What we need to document is the patient positioning. So we have to write the position here, and the form would say a yes or a no, or the remarks, if there are any specific considerations there. The surgical approach would obviously be a Cocker-Langenbach or a variation of the Cocker-Langenbach or the Gibson's approach. And what we essentially need to describe is the amount of tissue trauma that we see while we are going into towards the acetabular socket in terms of gluteus medius laceration, in terms of pulverization of the short external rotators, in terms of the relation of the sciatic nerve and its variations, especially with respect to the piriformis, in terms of how the capsule is, whether it is intact, torn, or buttonholed, and that essentially would have a bearing of on the quality of reduction, the vascularity statement of the head, especially in situations where there has been a dislocation. So those are things which I thought are important that we need to put together into a form. And the next step would be after patient positioning and surgical approach, that once we've exposed the fracture, what do we do? So basically, we need to confirm the diagnosis and make sure that we are dealing with what we expected to see on based on our assessment and pre-op assessment of the X-rays, the CT scans, and the 3D CTs and the axial scans. Then we have to basically be clear that what we anticipated in terms of the location of the posterior wall fragments is the same as what we are seeing on the table, and define and redefine and reconfirm the size, the degree of comminution, the type of comminution of the wall on the column, the presence of intra-articular fragments which would need distraction of some kind, either a lateral traction or a distractor or a manual traction would need to be assessed. And if there are fragments, the size of the fragments needs to be documented, and that can come into the remarks. The type of marginal impaction, the size of the impacted fragment, the requirement of bone grafting and a rafting of with screws and incarceration of fragments needs to be documented. And put into a form. Once we've done that, and when we proceed towards the reduction, basically what are the things that we need to need in our reduction process? For example, do we need lateral traction or trochanteric pin traction? And we can also add a distal femur pin traction on the table if necessary in certain situations. The reduction maneuvers that we need to do for a given fracture situation or the reduction of a particular fragment, the clamps used and the placement of the clamps, a note on the superior gluteal neurovascular pedicle, and any special C-arm views which might be needed for a given situation. And then coming to fixation issues, essentially the kind of plates and screws, the number and the type, the location of the plates and screws, the lag screws, if at all we need to use them, which corridor we need to use them for, the size of the lag screws, and the kind of the lag screws. And once we've done a fixation, essentially a stability check to see that the hip is stable and the fixation is secure. The other part of all fixations and all treatments per-operative is the perioperative protocol, which essentially means that once we've done a fixation, then do we mobilize the patient in bed? Do we allow bed to chair transfer? On what time frame? Do we allow them weight bearing or a pain adaptive weight bearing, partial weight bearing and a full weight bearing, and on what time frame? Then a statement on DVT prophylaxis, and it's very, very variable. So we use Clexane 40 milligrams for about 2 weeks, and in certain cases, high risk ones of about 4 weeks. But this has to be standardized. We have to agree upon a certain statement based on the evidence that is available, any history of HO medication that we give, and any irradiation that we need to use on a given case. So these are pretty much the form that we need to fill for whenever we need to go posteriorly, either for a posterior wall column or a column alone, or a combination of a wall and a column. A similar thing, an anterior wall and column, or the anterior combination of the above, basically skipping through. And again, the basic thought process is the same, that we have to intraoperatively document the patient positioning, and we can access any anterior wall column, wall, or a combination injury through many approaches. They can be done through an AIP, they can be done through an iliofemoral, they can be done through a ilioinguinal, depending upon the training and expertise of the patient, of the surgeon and the surgical team. So depending upon the approach that we use, we need to document. If we're going iliofemoral, then there are certain issues, whether we are using an osteotomy or not of any kind, either on the crest or the anterior superior leg spine. The nutrient foramen, which bleeds and which is essential to control the statement and status of the SI joint. We look at the pelvic brim. Define the marginal impaction and incarceration of the acetabulum, if at all there is a fragment and exposed head there. And then that is probably one position from where we can best define and have an idea about the femoral head impaction. Again, the anterior intrapelvic approach basically defined the osteotomies that we might need to use if there is a lateral or a first window which we have to use along with it. The statement of corona, whether it is venous or arterial, the number of channels, the location of and the number of anastomotic channels, and the location of channels with respect to a fixed bony landmark, which can be a pubic tubercle or a pubic symphysis or both. Whether there is the iliopectineal fascia is torn completely, partially, or to what extent. The obturator status of the obturator neurovascular pedicle, and then again the pelvic brim, the SI joint, and the marginal impaction or incarceration. If you're doing an ilioinguinal, we have to define it based on the 3 windows, the lateral, the middle, and the medial window, and essentially the same thing that we need to document. Again, the reduction can be defined into pre-reduction, reduction, and the fixation steps. The basic steps of the basic documentation would be whether we need to use any additional traction, any reduction maneuvers, the kind of clamps, the pedicles that we deal with on a given situation, any special views. And on the fixation part, the types of screws, the types of plates, the number, the size, and lag screws, if at all, the corridors on which we need to use a lag screw, and the kind of stability we get post fixation. Again, the hospital protocol, the DVD prophylaxis, requirement of an HO medication and irradiation remains almost the same. It is pretty much the same for a transverse fracture, where the protocol would be predominantly like the one that we use for a posterior exposure. So I will not spend too much time on this. And the anterior injuries essentially of different kinds. Again, the approach that I have quantified will be based and dependent on which approach you are comfortable using or prefer to use or try to use on a given situation. So again, the documentation for anterior injuries essentially hovers around the approach that you use. So it will define the patient position, the approach and exposure of all the structures, and the status of the pathology that you see on the given situation, whether you're using an iliofemoral, an anterior intrapelvic, or an ilioinguinal approach. And again, the basic intraoperative strategy has to be defined based on the quality of reduction, the reduction issues, the requirement of secondary approaches for associated injuries, the fixation statements, and the hospital protocols. And the statement remains pretty much the same for the associated injuries of different kinds, where you may use different approaches, more than one approaches, sequentially or staged, and everything has to go down into the documentation form for an anterior exposure, which is pretty much the same. On the pelvic side, again, you have to document whether the patient had a polytrauma and the kind of injury that he has had. And I'll go straight to the form. So essentially, on the intraoperative side, we basically need to again look at the kind of injury. So classification is extremely important and very, very important to define, because this will help us with defining the kind of exposure, the positioning, the approach we use, the kind of reduction tactics that we use on a given situation, and the kind of fixation that we need to do for different issues. So essentially, it is based on the approach that we are going to use, the reduction, the pre-reduction pathology that we witness, the reduction of and the various instruments that we use, and the kind of fixation that we need to use, and the post-hospital protocol. So it's pretty much the same and a little different for anterior and posterior injuries and the associated ones. So I will, rather than going into the details of the injuries, I will just look at the form which we are looking to standardize and use in our cases. So I'll stop there as of now. Sir, you are not audible.
Unmute kar lijiye, sir.
So I want to ask Mehul, when they're documenting their surgery, the details which Abhay has given are reasonably extensive. I think they can be put up into one set of a form in which it is approach and impaction, no impaction, like that, rather than getting into the different perspective, because that will make it very extensive. So maybe that's one part. But what I want to ask from Mehul, in Bristol, whenever you document intraoperative observations, how do you do it? First, observation, and then as documentation is concerned, do they use a camera? Which camera? As is a question also from Dr. Anil Shah. And video, the which way they want to do. Mehul, are you there?
Yeah, I am. Thank you, Dr. Sen. So, yeah, I think documentation is key. But I think as a surgeon, when we look at trying to do studies on this, it's really important, because all of these factors have some influence on the outcome. But I agree. I think trying to put all of this data on a registry may be difficult, because you will have a group of surgeons who will be very diligent and fill everything in. There may be a group of surgeons who are not as diligent, or who are overwhelmed with work, and they may not fill it in. So that creates a problem. So what we tend to do is, for our minimum data set, we don't have all the exhaustive conditions, but when in our operation note, we write in every detail what the classification is, what the injury pattern is, what the approach is. So everything Abhay has said, we write all of that in our operation note. And our operation note, as as one page or 2 pages as a Word document can be uploaded. So I think that may be a better way around it, unless you go to a digital system. If you go to a digital entry, like a REDCap, like what Chris was saying, then you can have drop-down menus. So you have approach, and you can have a drop-down menu, and you can choose one. And you can have 10 different items in there, but you only choose one. So then you can possibly do that, okay? With regards to photographs, videos, so we have a medical photography department, and if we want something photographed or videoed, then again, there's a consent form that the patient fills in, and a member of staff comes up and takes the photograph or videos it, and it goes directly onto the medical imaging system. So again, it's not all on one system. It's on a separate imaging and video platform.
Okay. So any more points which we can discuss at this stage about the intraoperative documentation?
No, I think it's important to have all that information, but I don't know whether the right place for it is on the database form. I don't know.
So let it be in the patient's case sheet rather than a database.
Unless you've got a drop-down menu, then it will be easy.
So it's always good to have a kind of a electronic system where you have a drop-down menu for all these things, for the approach and for all those things. Or maybe performa in which there are points to tick.
Yes.
I think we should have a single page thing. We can't do individual types.
Yes.
Once we write the diagnosis as a ACPTH or a both column or whatever, that particular patient's details will be there. Marginal impaction, approach use, whatever, or 10 or 12 important points can be ticked off.
So they have to be combined into a single page.
Single form, yeah. Single
form as far as the operative findings are concerned, in which I think that work has to be defined like that. Just like a preoperative form, intraoperative form, where all the findings, and maybe we can have separate for the post-op days for 1 to 2 days, because there is likely to be variability in the day 1, day 2, and day 3. So that can be different, but operative findings with all those, the approach and the findings intraop, whatever it is, has to be a single form in that way. Will that be okay? And anything to add on this documentation of a finding, and as said it, what is the kind of the camera, which camera is best? Intraop record of pictures, Dr. Anil Shah has asked about. So anybody wants to tell about which camera they use for this documentation?
We use the normal mobile phone cameras nowadays. They're very good. Actually.
They're very, very high powered. The question is, what is basic assessment? Because I remember 20 years back when I got the first camera, that was Nikon 900, 995. They said that for a medical photography, you need 1.3 or 1.5 megapixel. That's all. You don't need any more camera beyond that. But I'm talking 20 years back. So what is the standard today? That because it all depends on how you want to use it. If you want to use for publication purpose or like that.
It doesn't depend on the megapixels. So nowadays, all the cameras, any average basic phone is good enough actually.
Yeah, no. All these they are coming to 100 megapixel even now. So things have changed now. So then we can go to the next part. Krishna Kiran, we can go to the post-op.
I'll tell you. So what I've done is I've actually put together the patient reported outcome measures as a part of the post-operative protocol. So we have some which are free and readily available online as a form which can be downloaded. The second thing is the clinical and radiological criteria, which again are well described both for pelvic and acetabular fractures. We just need to incorporate, as Dr. Pranav was saying, the certain features which are important for Indian patients. The enormity of the challenges before us, the Swedish arthroplasty register was started in 1975, and it took 25 years for them to reach 100% accurate data collection. So it's not going to be an easy task, and accuracy of data as well as compliance with 100% registration will also be a difficult thing. But I think it's something which we were wanting to embark on for a long period of time. The rehab protocol for unstable pelvic and acetabular fractures is more or less similar, with non-weight bearing ambulation with crutches for 6 weeks, toe touch between 6 and 12 weeks, full weight bearing after 3 months, and return to sport after 6 months wherever it is possible. So I think this can be uniformly followed across the country. Typically, exercises in weeks 1 and 2 are simple range of motion exercises in all unaffected joints, strengthening exercises for surrounding muscles, and gentle massage on tight muscles. Weeks 3 is partial or toe touch weight bearing under supervision, gradual strengthening and range of movement exercise of the particular involved joint or pelvis, and re-education on parallel bars, upper limb strengthening and cardiovascular activity, continuing with soft tissue techniques such as massage, pain and swelling control, and progress to stair climbing if appropriate. So these are all standard rehab protocols which can be incorporated into all our, because they'll be important for documentation as well. Between 7 and 12 weeks, the patients can be fully weight bearing based on individual situation, more specific and functional activities, and gradual injury to return to pre-injury lifestyle. Now, DVT prophylaxis, HO prophylaxis, again, ideal drug and duration is questionable. I think we can agree, all of us, on what we need to use and the duration for both of these. And this can be standard across the AOPAS group at least. Now, the outcome documentation should be done at least at 6 months, 1 year, and 2 yearly thereafter if there is no problem. And if there is a problem, based on the problem, the patient must be called back as and when required. And the outcome for pelvic fractures is based on clinical and radiological evaluation. And the Majid score is established and validated technique for pelvic fractures. This is available as a simple a tick list which can be incorporated into our data form, which looks at pain, work, ability to sit, sexual intercourse, and standing, which is looking at walking aids, unaided gait, and the walking distance. So you have 100 points. And the classification is based into 2 groups, satisfactory or unsatisfactory. If the score is above 70, then the outcome is deemed to be satisfactory. If it's less than 70, then it's an unsatisfactory outcome for the patient. So it's a relatively simple and easy to do score for pelvic fractures. Now, radiological evaluation, the question comes is whether only plain X-rays are adequate or CT scan is also required. On plain X-rays, you must do the standard AP inlet and outlet views of the pelvis. And again, the grading is excellent, good, fair, or poor based on the amount of displacement in any direction. It could be superior displacement, or it could be widening, or a lateral displacement, or any sort of displacement more than 20 millimeter is considered to be poor. Again, easily doable for any average surgeon. The literature suggests that we must routinely use CT scan whenever we use iliosacral screw, but not for other type of pelvic injuries. The reason being that in more than % of cases where the intraoperative and postoperative X-rays are deemed adequate, the iliosacral screw was found to be in an erroneous position or the trajectory was wrong. So CT scan only for iliosacral screw fixation. Coming to acetabular fractures, again, outcome documentation at 6 months, 1 year, and yearly if there is some evidence of arthritis, or 2 yearly there is no evidence of hip arthritis at 1 year or any problem. 4 things need to be looked at: complications, the clinical and radiological data. Clinical data is physician reported and patient reported. So again, we have standard and accepted data forms for these things, which can be incorporated to our patients. And we must look at the complications like conversion to total hip replacement. So all these complications need to be documented, starting from neurovascular injury, whether there are intra-articular screws or a broken drill bit, whether the reduction is perfect or imperfect, whether there is infection, DVT, other systemic complications, loss of reduction at the time of follow-up, AVN of the femoral head and the acetabular wall fragments leading to subluxation of the hip, chondrolysis, heterotopic ossification, again by Bruker's classification, form is available, or development of radiological osteoarthritis. So this is the MATA's modification of postal score, which is again used for total hip replacement as well. So this is based on 6 simple questions. Do you have pain? Does it require medication? Are there any activities that you can't do now but could do before the acetabular fracture? This is what Cyril was talking about. Can you sit for a prolonged period of time, or does hip pain or stiffness require moving at intervals? Can you participate in sports or exercise activities? Do you work, and did you return to your pre-injury occupation? So these are all the questions which are asked, and the points are given based on the outcome. And they also look at walking, range of motion, which is measured. The rotation is measured in prone position, and other movements are measured in supine position, and the comparison is made with the hip. So if more than 80% of range of motion as compared to opposite hip is achieved, then it is a satisfactory outcome. But if it is less than 80%, then that means that the outcome is not great. Again, it's a simple system, and it's been validated over last 30-31 years. So I don't think we need to change this. And based on the clinical score, the patients are graded into excellent, good. So we can ask the members to do the scoring and just mention whether the clinical score is excellent, good, fair, or poor in that particular patient. So our data form doesn't need to have everything with respect to all these things. This can be done locally, and just the excellent, good, fair, and poor can be mentioned in the outcome. The problem comes for the patient reported outcome measures, and this is the smallest thing which is available, the short musculoskeletal function assessment. So this will give the general quality of life. Again, it's 2-page document, and the score can be mentioned on the on our database. We don't need to have the entire form. These forms, the local surgeons can fill it up, and whatever score comes in with respect to the SMFA assessment can be uploaded onto the data form which we are going to create. Now, it is up to our senior faculty members to look at these outcomes specific to Indian patients, the ability to squat, sit cross-legged, use public transport, especially the bus or the train or something like that, and agricultural work. So these are not included in any of the Western scores. So we can actually add these things to our thing, and it will make it more meaningful for our own thing. Now, radiologic assessment, post-operative, we have criteria, MATA's criteria on AP and Jude radiographs, and also the role of routine post-operative CT. MATA classified as anatomic, imperfect, or poor on all the 3 views, and we all know about this: 1 millimeter or lesser, 1 to 3 millimeter, or more than 3 millimeter. Again, the local surgeon or a group of 2 or 3 surgeons can rate the X-ray, post-operative X-ray, and we can just document whether the outcome was anatomic, imperfect, or poor on the final data form which we are going to store. Now, CT criteria on axial, sagittal, and coronal cuts were available. Again, as Abhay nicely mentioned, the shift and step. So these things must be looked at, and it is feasible to routinely include CT scan is again up for discussion. But it has been shown that nearly 30% of patients where the X-ray looks reasonably okay can have a CT scan which shows an imperfect or a suboptimal reduction. So this is something which we must consider. So we must look into take into account the financial considerations or options for our own patients. And there is a lot of evidence that computerized CT scan versus X-rays, the CT scan is more predictive for native hip survivorship. So this is an important thing which we must discuss and decide on. And for delayed radiologic assessment, Mata et al. Looked at the hip, and again easy, excellent, good, moderate, fair, and poor based on the appearance of osteophytes, presence of joint space reduction more than 50%, and femoral head collapse and wear. So this again is simple to do, and we just need to mention whether it is excellent, good, moderate, fair, or poor on our final data form. Now the last thing is the short form 12 health survey. So we have to decide whether we should use the musculoskeletal assessment form or the SF12 health survey for our post-operative assessment. So I think we can start discussing now the presentation.
Thank you, Krishna. There are a few things which I think are very, very relevant. I have been documenting my data for some time, and I have been evaluating it. Now the questions are the follow-up. Our patients do not come for follow-up. So what the ways which we think, as I was talking in my introduction also, that we will have to use our smartphones or phones for that purpose, for that outcome. And for that purpose, maybe that we are not able to come up that quality of outcome assessment. But if you look at those criteria which patient can say, the ability to sit, the ability to squat, the ability to walk around, because if, as you gave the mention of a score which has proper scores, range of movement 30 to 50, 50 to 60, it becomes very difficult. I have been analyzing all these scores for last 10 years, 15 years. My physiotherapist does this job. How accurately she does it, I cannot say it out, but she makes it up. I keep on cross-checking in between. But if you want to have a uniformity all over, rather than looking for that kind of a score, as you rightly said it, we have to look at the ability of the patients.
Yep.
Ability to squat, ability to sit. And I found it out, it's much more relevant.
It is
as
relevant.
well. The problem with those registered scores, and technically you have to pay the registration fee and license fee to these people. I personally feel using WHO quality of life score is simpler, it is free, and it is available in many Indian languages also. So I personally feel that using a score, and when you say about ability to sit and squat, we have modified HERISIP score for this very purpose about 10 years back, and we have validated these modifications in which we have added sitting on the ground and all those things also into that score. So we need those kind of situations where our follow-up has to go accordingly, in which we do have a better compliance, because our agriculture patient has, our rural patient will have a different perception of his abilities. And now talking about cross-leg sitting, a lot of patients, they say we don't sit on the ground, we never sit on. But then I ask them, can you sit? Then they sit, and I ask them, standing on either side, the other leg lifted. So that tells me about the abductor strength. Sitting cross-leg tell me about their range of movement, and then their gait, that tells us about this thing. So these are the simple parameters which I have found to be useful in your routine assessment of this patient as far as his abilities are concerned. And then you have a questionnaire, a defined, whatever the questionnaire you design it out, how difficult, what is the pain characteristics, and what are their other characteristics. So I think we need to work on it. We may not come to the world standards, but these are our own standards which we will have to work. So I think that is an important part in perception.
So totally agree with you, sir. We will look at the, this is what is the summary of what is available to us and what is the standard way of reporting acetabular fractures. So what we have to look at is, if we report them at some point in time, there must be a validated way of documenting the outcome. If you don't have a validated way of documenting, there may be some issue with the publication itself. So that's why I got out only those which are free. The musculoskeletal short musculoskeletal assessment score is free, so you don't need to pay anything. What we have to do is, we have to make it suitable for acetabular fractures, which I will do. I will take out the parameters which are not relevant and get them to be looking at parameters which are suitable to us, and we have to translate it into language.
There is a issue. When you validate a score, you cannot change any parameter till you have validated the change parameter. And this validation requires a very big study. Because when we were doing this validation of our modified HERISIP score, we studied 550 patients, in which we studied three. We studied modified system, we studied original system, we studied their quality of life system, and we studied their SF36 system. And then you used all those scientific methods to validate that score. And in that score, whenever you ask a question to the patient, there is a ceiling value, there is there is a lot of science involved in changing a score also. So it's good to have, as you say, SMFA score is okay, so we'll have to stick to SMFA score.
Correct,
or
because
that
has been validated in Chinese as well as Spanish population. So you have Asian
but then you need Indian validation.
Correct.
You cannot apply a score validated for other population into Indian population.
Correct.
That's a very, very important point. in WHO quality of life score has been validated sufficiently for diabetic patients, for pulmonary in Indian population, for most of the diseases. And we have our first in 2011 also we have validated in established population also, because the validation requires the normograms of that value and then the affected grams of those values in those cases.
So then instead of postal score, we will use the modified Harris-Ip score, which you have already.
Yes, this is validated right now. It is getting published also.
And the WHO quality of life scores.
Yes.
So these two we
that
will
I feel
incorporate.
personally is they are simple. Initially, WHO quality was very big score. Now they have come from 24 to 12 points. So I think this makes it comfortable to analyze also. And my personal perception always is have a standard person, a physiotherapist doing it always.
Yeah.
Everybody will have a physiotherapist with them, and let a standard physiotherapist assessment. There are two benefits in that. You are unbiased because he or she will examine the weight, and she's standard. I mean, you have to cross check her that she's maintaining or he's maintaining the same set of quality in evaluation or not.
Yeah, I think
because you will never have that much of a time to ask every patient whether he's doing it or not. So there has to be somebody well trained in it.
So we will have a four-page
yes.
questionnaire. I think we can make the in pre-op
yes.
single page thing. Abhay can make a single page for intra-op documentation. I'll make the 2-page for the post-op documentation.
Right. Okay. So that way we should be able to come out with a format. And let's see what this Pranav has to say about the ethical part, because there is a very, very important part which Mehul said it. Mehul showed very beautiful this thing in the last 2 or 3 forms, which probably we can get and have accordingly notified in our Indian things also. Pranav?
Yep.
Yes, sir. I have an unstable connection, so I will put my video off and just come to the slide.
Right. Okay.
Okay. So we are talking about pelvic acetabular fracture database or registry, the legal and ethical issues. The issues primarily are related to our association, the AOPAS. So the AOPAS actually has to make an amendment in its constitution and empower a AOPAS designated committee, which will collect data, process the data, publish the data, and if possible, create a registry. And all this is to that designated committee, and the responsibility and liability of AOPAS is for the surgeon patient confidentiality, as well as to generate a surgeon report annually. So we'll come to that. Now, in India, all the medical research is under the Central Drugs Standards Control Organization, that is CDCSO. It is under the Minister of Health and Family Welfare. And they have no guidelines. I have gone through their website. They have no guidelines for ethical issues related to a registry. But when I talked with my own hospital ethics committee chairman, she told me that since what we are undertaking is not a clinical trial, we are not using any new or unapproved therapy or drug or a medical device, and we are not deviating from established protocols of standard care. So we don't require an ethics committee approval as such to conduct the collection of the data. Only one precedent is there about the registry based at Bangalore under the ICMR, the details of which are shared with Dr. Sen. Other than that, there is no registry related any data on the CDSCO website. I also talked with Dr. Pachore, who is conducting the ISHKS, Indian Society of Hip and Knee Surgeons Registry, and he gave me the name of a legal counsel. He will also share the number, who can guide us if required for the legalities in this aspect. Now, the patient issues here will be getting an informed consent where the patient agrees to participate and to follow up for a specified or a lifetime. I mean, if we are looking at long term, probably we are looking at 10 years, then they will have to consent that they will allow us to get in touch with them and enroll them and get them to do the required follow-ups for 1 year or 2 years or 5 years or 10 years that we need to finalize, then the patient confidentiality will be protected. That is one thing that we have to assure to the patients, and that is where that the very nice word that was used by Cyril, de-recognizing the patient, means that patient, anything that we upload or anything that we share, the patient name and patient data is deleted from there, and then we can go ahead. Then we come to the or by phone of telephone, or by sending a form which the patient can fill and send back. So this is again an issue, because many times the patient will not follow up with the doctor after 1 year or 1.5 years, and we still want the 5-year data of that patient. Then we may have to take the initiative and follow up with the patient, for which the patient has prior
Yes, there is a problem with Pranav's connection. Pranav, you are not audible.
Unmute yourself. You need to unmute yourself.
Okay, now I'm audible?
Yeah, that's right. Right. Again, not audible. At least you seem to be muted. Yes.
Can you hear me now?
Yes, surely so.
You can hear me?
Yeah, that's right.
Okay.
Again, you're muted.
You can hear me?
Yeah.
Can.
So I think you all went, everybody saw these patient related issues.
Yes, quite okay.
Okay. So then finally we come to the surgeon related issues, where the surgeon also may want to maintain his confidentiality when the data is being processed by the closed group or the third party, whoever we assign to. And then there is also the surgeon who, once he enrolls, he has to have a certain level of commitment to upload all the relevant data without a financial incentive. So that is something that we'll have to really motivate a group of surgeons for doing that. Another will be the issue of sharing complications and poor outcome and poor reduction. So that is one thing where, usually with all registries, they have this concept of sending an annual surgeon's report, which means that it is a overall data of all the patients that he has uploaded, and any, summarized version of say 15 cases were operated by you, these were the cases and this is what was done and this is the outcome and this is the 1 year follow-up, that kind of surgeon report. And whether the overall outcome, like 150 cases were enrolled in the entire year, out of which these many were, these were the outcomes in these many patients. So that things can be shared or not with the surgeon. That is another issue that we have to discuss. The problems that we are looking forward is one is duplication of data, for which Dr. Vivek Trika suggested that Aadhaar card linkage. That was very important because many times patient changes the surgeon during the course of treatment. So either we lose that patient or there is a duplication of data. So that. And then we have the problem of patients being lost to follow-up. So many times the surgeon will not have the kind of motivation to go after that patient. So then can we pursue after that patient even if the surgeon has given up? That is.
I think he has issues with internet again.
So
that covers up. Okay, so I think you saw the 6 slides. That was all that I had to share with you. Yep. There is a very detailed registry related document which I have forwarded to Dr. Sen.
Yeah. Now I consider 2 things first. We understand that we are talking about a registry, but right now our aim is that we are able to have our own records. The requirement that tomorrow, if we have to develop to a registry, that data accumulation can be amalgamated at one stage. So the question of today is probably limited to that very area, which is a simpler, which is to be done by all of us. And let's all have a common performa, common this thing, common requirement as prepared by Vivek, Abhay, and Krishna Kiran, and then accordingly go with that. And probably the consent form, I still feel the Mehul, which is the consent form he has made, are quite okay. We can replicate them in our system also, the similar kind of a consent to be used, because this consent we will have to take for subsequent role also, because we will be using this very data. So from the consent point of view, we can have the consent for right now also, and for the purpose of putting up in the registry. But all other data we are right now doing with the aim of two ways data. One, as Mehul said it, a combined kind of a registry where we will be building up, and then our individual registry. Because tomorrow, if some of us decided that we want to work on posterior wall, then all of us collect our posterior wall, and then we can dig deep into our areas of posterior wall, and then we can work on those particular things. But let that the detailed data remain with the surgeon, the basic data come to a registry level. And now let me ask Krishna Kiran another thing. You are putting up your data in Ishq registry with Northgate, isn't it?
Yeah.
Are you able to get the feedback from them how your cases are doing?
No.
Because let me tell you why. The Northgate in India is providing very minimal registry, not the registry which they are giving to the UK people. Yep. I had a lot of discussion with them about 3 weeks back when I was discussing with you. They are not ready to really spend even a penny for Indian this thing, because what they are doing, this is just a software company. You are doing all the work, you are documenting every data, you are putting up into their system, and their software doing it. And for that software, they are charging exorbitant amount of money. I discussed with few surgeons in UK also, and few other places also. There are many other, just RedCap, and there are many other these things which have got very good software thing. And in India, we have got a lot of software things. So we should not be looking for that kind, because Northgate is supposed to be giving it a very high cost.
Yep.
And their work is just software. So we are paying. In England, as Pranav was saying, they are giving the feedback. They are giving, if I have studied all the registries, they are giving only the feedback on the mortality of the persons, because they are taking the patient related outcome measures, which again, the English surgeons are filling up. In India, even that is not there. But I insisted with them that in India, because in England still it is okay because the patients are under NHS and they get reported anywhere. In India, that reporting doesn't go with them. In India, we need patient-related outcome measures to be asked by them after 1 year, 4 years, 5. Because if they say about the failing hip or revision surgery, which will happen 15 years later, and our Indian patient might have got replaced at somewhere else. So we do not know whether it's right or wrong. So I am personally very careful about that. We need to have our own software, and for that we have to work our own self. Software is not a very costly thing. So if we have our own registry with the basic things, so what a software requires is a proper filling of the data and very basic data. We don't have to have a very advanced kind of a data. And as you said it, that when we are looking at the patient outcome measures, we do have a numbers only, good, bad, and this thing that way. So if we are able to have this kind of a basic data to be filled up in the registry, this will probably solve our problem to a big extent. And the problem is follow-up subsequently, because without a follow-up, no data is useful. But for me, I can virtually say it, the ISHK registry, because I try to look up the paper which they have published also. You might have seen that it is just a data, this many put up, this many given, this is the implant used. But what happened to them? I mean, we are waiting for 20 years now to know what happened to them, and then we are not very sure how many are actually the real data or not. So I'm a little skeptical about until we are not ourselves active about it. And so we will have to have our own assessment criteria, our own active management in follow-up. A surgeon has to take that care, and which has to be very basic minimum, in which at least patient says he's doing okay. I mean, it may be just that he's able to walk around, he has no issues. That is sufficient for that level of outcome, which I say on telephone. So we might have a 100% or 80% outcomes on phone, and about 20-30%, because our patients won't come back after 2 years, 3 years, 4 years, 5 years, unless you are after them for everything. So we do good analysis in the patients who come back, but we do have some idea about the patients who have not come back but are traceable by telephone. So our registry will have that level of interaction also, a telephonic interaction and a personal interaction. This is what I was thinking. Because to make it applicable without a follow-up, nothing goes.
Makes sense, sir.
Yeah.
Only patients I see for follow-up are those who come for a legal case or something, 7-8 years.
Yes. Because no, at least I remember 5 or 4, Vivek might remember, Abhay might remember, who are doing thesis with their boys, that if you give a thesis to the boy is struggling to ask them to come back, even if their telephones are okay. And they don't want to say, no problem, why we should come back.
They are asking money also. They're saying, "Humko paise doge to fir aayenge."
So,
I mean, we have been paying people to come to the hospital and get the things done. 500 rupees की आने जाने का खर्चा हमसे लो, लेकिन आओ उसके बावजूद नहीं लोग आते सर.
नहीं आते. If they have no,
that is what I'm saying. So our system must take care of that part. We should not accept at that level. We should have that. Chal, tu nahi aayega, no problem. Let you have a telephonic discussion. At least we know what he's doing.
Yeah.
And if he's good enough, he can send the X-ray also.
I think the four questions, whether he's able to sit on the floor, squat, walk, and then use public transport and this thing, that should be enough.
For that purpose, we ask him, can he go upstairs or not?
Yeah.
Because getting over to a rickshaw, getting over to a bus requires a certain amount of going up and down. So what my physiotherapist asks, whether they can go upstairs and they can go outside, and when going up, do they use a handrail or they don't use a handrail?
Correct. Yeah.
So this kind of a question.
So we can have that kind of the questionnaire formulated and validated. We can like the AOPAS questionnaires, and then if
I have validated this thing for my joint replacement patients.
He's already done it for Harris-6 score modified.
Yeah. No. Another one. This telephonic score also.
Telephonic. For pelvis and acetabulum, just minimum basic functionality, so that 4 or 5 questions which can be asked objectively on phone.
Maximum 5 questions. The patient's call will not last beyond 5 questions.
Yeah, exactly. So exactly.
Then they will come to kitna paisa dete ho. Up to 5 questions they will answer. Otherwise they will not.
They will not answer. So this is important that in India, in our system, for our directory, we will have to revise our these things. and have to come up so that at least we can say these patients are able to walk around. And whenever you have got a doubt, whenever you have got a particular issue, you can go after the patient to get more data. But overall, we know that they are doing okay. So
if we can make and publish it so that you later on publications, because those elaborate this thing will be not be possible in our setup. So at least
No,
this
not
thing, so we can at least show that the long-term data follow up, long-term clinical the outcome means functional outcome are there.
So what we can do
Minimum
is we
basic
prepare a telephonic score and we ask, we validate this because 6, 7, 8, 10, 15 of us will use this score also as a standard score also, and will validate that. So if our number goes to 400, 500, 600, it comes to a level that we can publish the validation of this telephonic score also. And then we are okay with to use it subsequently also. So that
we can justify it for the use of developing countries.
Yes.
So Dr.
We can
Anisha was
justify the
asking
use
if,
for developing countries.
Yeah, that's right. Pranav, you're asking.
yeah, Dr. Anil Shah was asking about any retrospective study that we can conduct.
Retrospective study, again, because we don't have the standardization of the data. And if we don't have standardized data, it will differ a lot.
Yeah.
Yes. So I think we have to look prospective.
Yes.
We have to collect data prospectively, then we can retrospectively analyze the
Incidentally, I don't know, time is already over. I am analyzing with this situation of lockdown. I was looking at all my 1500 cases which I had operated upon. A very big factor which probably even Vivek might have to take care is delay. When the patient presented to us 2 months late, 1 month late, 4 months late, 5 months late. Because in India, that's a very, very important thing. Massage and manipulation done or not. Because in India, that's very important. So I could get many of these unusual things which don't come into the Western data. They are our problems also. So I think we need to have Indian systems in our preoperative workup also. Operative will remain the same, except for maybe that we may not be able to document everything, but operative will not differ. And outcome score again will have to be developed according to our Indian systems.
Sir, I think, of course, this what we are undertaking, that ultimately we want to create registry, is a good thing. But I think more important that we should first come up with standardized protocols. At least on that AOPAS letterhead, or as a AOPAS body, we should be able to recommend at least the standard of care for a level 1, level 2, and level 3. Like for a district hospital or a private hospital, for a community hospital, and for a trauma center. At least we should be able to come up with these guidelines.
I think you cannot have a guideline which is separate and different for different patients, sir. In this country, everybody has to get the equal sort of thing. So you cannot have written guidelines saying that if he is in a level 1 center, he should be getting a CT scan done iliosacral screw. And if he is in a level 3 center, he should have an X-ray based iliosacral screw fixation. You cannot give it in written as such. The guideline has to be a bare minimum, only a bare minimum that this should be at least followed. If you look at Bristol score, which Mehul was showing, it is very basic, which can be followed by a house acad surgeon or a non-acad person also who is in the emergency, that he has to do this, do that, and finish. Guidelines cannot be different for different hierarchy of tier 1, tier 2 cities.
I think if we can start following a standardized pre-op documentation, intra-op, and a post-op documentation protocol, and we can continue to do it for about 6 months to a year, then we will be wiser what is happening and what is not getting done. I think right now it is just
if we just have a 3-page or a 4-page
absolutely
all the 6 people who are here, first all the 6 people who are here, or many people who are listening also, should have their own documentation and see what all they are missing. I'll tell you, when I was looking and I was showing you that Excel sheet I have got for around whatever patients I have, and I copy and cut from there and do it, there are things which are missing. And luckily for me, I have a PAC system and a CPRS system where I can go back and look at all my computerized records. So I myself, even relying on a fellow or anybody, I myself fill that up right now in the 2 months lockdown period, and trying to fill up all the gaps which are there for my own study. So imagine how difficult it is. and it is going to be first, everyone has to start documenting that for medical legal purpose, let's say that way. Then we start looking at for the patient's welfare, and then after that, once we have developed the system, then we go in for a further level, maybe hospital and registry level system. That is the thing. So in individual documentation, as you said, in a standard of care treatment or a minimum documentation of that is a must. Maybe not the technical points of what we are getting into, because technical things might differ from person to person. But
Hey,
at
now
least
let's make it a timeline. Let's make a timeline when we should be ready with the this documentation
1 week.
needs.
1 week.
Format.
Is okay, yeah.
Is that okay?
So
1
1 week we should have a rough draft, and then we can discuss over it again at 1 week mark.
Yeah, we can put up in the this thing also in the group itself, and then we can discuss about it. But let's come up within a week. Is it okay with everybody?
Yeah, 1 week.
You need to define for what exactly the goal is for making this documentation.
Right now, individual.
Yes.
First, and a subset for this thing. Out of those individual 40 points, 10 points for a registry.
Right.
Because we have to understand this. And I mean, Mehul was very right in pointing it out, this very thing. Something for a registry and main thing for us. Let's us have the proper workup and tick 10 points which can go for a registry.
Yeah, so we have separate forms for pelvis, separate for acetabulum.
Yes,
Let us start first with that. Then
and
what we can do is like
the
all the three
possibility
people.
of combined also. There will be combined cases also.
Okay, yeah. So then in that case, you have to take, fill it in one and then addendum on the other side, something like
Section
that.
A, Section B will be like that. Section A and Section B.
In a week's time, let us come back with something, and then it can be worked upon further.
Yeah, so the three people who did the documentation talk today, they will come up with 20 or 25 or 30 markers. And then next meeting, we will be, we can discuss that how much of that is relevant, how much is to be left out. So that we come to a standard subset ultimately. If suppose Abhay is coming with operative documentation, the other 5 people, Abhay will try to say why those points are important that he has included. And then the other 5 people say yes, no by voting. And by ideally, you try to get that into a 25 point or 20 points. Similarly, 20 or 25 points for pre-operative, similarly 20 or 25 points for post-operative. So we have at least a 75 point checklist for our each patient. Once we standardize that, then we can, put it into our group and enroll. Say 10 people will get enrolled, that from next day, they will start using all this standard format for their patients. So by the time we have our next annual meeting, at least we have a data from 10 or 15 or 20 people who are doing it this way, something to start with. And then we can, think about it.
Quite okay. At least I think we make a start, and that way, let it be their day to start the things. Is that okay? So I think foreign faculty is already left. So we thank them and ensure for their participation. And let's hope we go further with more and more AOPS work. But I think I am really thankful to Pranav and Pradeep that we have been able to use this time very efficiently, and probably the kind of inputs we are having and the kind of the outputs we are getting is one of the best probably across the world. We cannot have anything comparative. Even in USA, I have been talking to many people over there also. They don't have this level, and that's what we were talking to Saji also at that time. That at least we are thinking at that level in which nobody else is doing this. So this is a great credit, definitely, in this kind of a situation. So thank you, everybody, and thanks.
Good night.
Thank you.